This topic is, still we are talking about hepatitis B, and the question is, do we need to treat all? It's not that do you want to treat all, it's not like can we treat all, the question is, do we need to treat all? Why to treat? Only if you know why to treat, then you will know the answer for who should you treat. Why to treat? Because viral hepatitis is a dynamic disease. Hepatitis B, it's not like A, it's not like E. And then there is a proportion which will progress to chronic hepatitis, cirrhosis, end-stage liver disease, and then you may even require a transplant. And the most important is it is a carcinogenic virus, and we know these carcinogens, the longer they are with you, they have a higher potential to go in for malignancy. So why should anyone allow a child to harbor this sinister virus with so much of a bad potential? So this is the reason why to treat, and the next few slides will give you some reasons why we treat. This is a unique virus. It's probably one of the only DNA viruses of the hepatitis A alphabet, and the only virus which produces an antigen continuously surplus amounts, so you use an antigen to make a diagnosis. Most of the viral things you always do antibodies to make a diagnosis. This is one virus where you can continue to use antigens even in chronicity and say yes, they've got the infection in the past. And we know it's a parental, and the unique thing about this life cycle is when the virus enters the hepatocyte, it's in a very relaxed atmosphere, the genome. But then as soon as it enters, it integrates into the nucleus of the hepatocyte, and it becomes a very complex, it becomes a circular, and it's a covalent DNA. And that is the most important part of this viral replication. And because of that, because we do not have any surrogate markers to test the cccDNA, we do not have any medicine to treat this, and integration occurs even at the time of entry of the virus, we realize that there is no cure at present for hepatitis B virus infection. It is only a functional cure where we decrease the HBsAg, we decrease the, and probably seroconvert to anti-HBs, but that part which is already in the nucleus we have not touched, and there's always a potential that the person who harbors the virus can go for hepatocellular carcinoma. This we should remember. This we should remember, and that is the problem till we say at present there is no cure for hepatitis B virus. And in the natural history we all know, if a child gets, a little child more than 5 years, the incidence of going in for chronicity is definitely lower than the one when it gets in the neonatal period. The 5 to 10 years, it will be around 5 to 10%, but the younger the infection, younger the child when it gets the infection, it is inversely related to the age of acquisition of the virus, and therefore 90% of neonates may go in for chronicity if they get it from the mother. Whereas older child, we know 5 to 10% will go for chronicity, and by the time they reach adulthood. So this natural history is even a child can go for hepatocellular carcinoma, but the proportion is less, 0.01 to 0.03%, and 5% will go for chronicity. Then we know hepatitis, then we know cirrhosis. But what I want you to remember is sometimes you go through some phases even without going in for the cirrhosis. So you can jump from chronic infection, and sometimes you just go in for decompensation and for hepatocellular carcinoma. This slide I want you to see, because this is very, very important, that though we say chronic infection, it just doesn't be chronic hepatitis and cirrhosis. This is what I was trying to tell you. Sometimes the virus lies very quietly, a phase when the body immune mechanism and the liver are all in a balance, and another way you think it's an inactive carrier. Just look at the virus, it's not unidirectional, the arrows. There are arrows which are going bidirectionally. You think the virus is sleeping, you think the virus has become quiescent, it might clear, but then suddenly it gets up. And this is what you should remember, that even in immune tolerance, you think that everything is quiet, that child can also go in for hepatocellular carcinoma. So these are the several reasons why we have to treat, and you know that hepatitis B virus infection in India is also, we lie in the intermediate period, and this study where they have shown in children the true prevalence among tribal populations in India is as high as 15.9%. So you know the reason why to treat. Do we have any weapons to treat? Yes, some are approved. We have lamivudine, we have tenofovir. This salt is approved, isopropyl fumarate, entecavir, all in children more than 2 years, entecavir more than 12 years. interferon and peg interferon are used, and then we have our liver transplant. But what is the efficacy of these antivirals? Just look at this. It's all around 24 to 25% HBeAg seroconversion and DNA negative. That's all. Though they are good long term, and you get only this if you use it as monotherapy. Only interferon, if you use, can change the loss of HBsAg, which may not be seen much in the other antivirals. So loss of HBsAg is probably the thing, an advantage which you will see in interferon. So you know the reason why to treat, you know the reason how to treat, but who to treat is the question. This is a spectrum of hepatitis B virus infection. You have the perinatal transmission, and then you have the infection which majority are asymptomatic. It could be acute or chronic. In acute, you have acute hepatitis, acute liver failure. In chronic, you have chronic infection, EAG negative, EAG positive, and then this can reactivate. Then you have chronic hepatitis. I want you to differentiate between this infection and hepatitis, and I will tell you why this is important. EAG positive, EAG negative, you have cirrhosis, compensated, decompensated, they can go for end-stage liver disease and hepatocellular carcinoma. So this you should be able to say, would you like to treat all or would you not like to treat all? And this would be the spectrum. Perinatal transmission, as I've told you earlier, the vertical transmission, the risk of getting chronicity is higher when the mother is both SAG positive and EAG positive. So till date, what we were doing, we were giving them the active immunization and the passive immunization, passive as soon after birth or within 6 hours, and we were giving the active immunization, the universal immunization, which has really improved and brought down the incidence of HCC in Taiwan, and India has also taken it up in a very big way. But then, when the mother is SAG positive and EAG positive, you find that even an adequate active and passive immunization, more than 10% of neonates are getting this infection. So, and they found that the relation was more when the viral load in the mother was very high, especially more than 10 to the power of 6 copies per ml. So, till 2012, we were using this algorithm where a mother who's HBsAg positive, even if it's asymptomatic and for herself she does not require treatment, you have to reevaluate in the 3rd trimester around 26 to 28 weeks, and then you sort it out. If there is a previous sibling history of death or any other thing, then even a HBV DNA of more than 10 to the power of 6, you start treatment with antivirals, and at that time LAM and tenofovir were advised. And if there's no sibling history, and if the DNA is less than 6, then you just monitor. If it is more than 10 to the power of 7, you treat. And this was the thing recommended, but now the new guidelines, more or less the same. All the 3 guidelines recommend the same, ASLD, EASL and HEPASL guidelines. Yes, you have to treat the mother who's HBsAg positive. When will you treat? When the HBV DNA level is more than 200,000 per IU per ml, that is more or less more than 10 to the power of 6. When will you start treating? The 3rd trimester, but there is a slight variation between ESL and ASLD, but probably we start at 28 weeks, continue till 12 weeks, so till the mother starts it, and then what is the medication now recommended? Though it is not class A, probably class B, tenofovir is advised for that treatment. What does APASL say? Yes, you have to treat antiviral therapy when the HBV DNA is more than 6 logs or 10 to the power. So you know that this group requires treatment. Perinatal transmission requires treatment. What about acute hepatitis and ALF? Acute hepatitis and ALF, who requires treatment? Only those who have severe acute hepatitis. That means coagulopathy, encephalopathy, ascites. APASL says bilirubin more than 10 milligrams %, and prothrombin time prolonged. That group, they have found that if you treat, probably you can prevent them for going in for chronicity. But you know, not very clear, but all the guidelines, whether ESL, ASLD and APASL, feel severe acute hepatitis, you can treat them. And how long will you treat? You have to treat till HBsAg clearance or indefinitely or till they go for a liver transplant. What is the medication you will give? You can either use tenofovir or entecavir, but there is no role for interferon. That means in acute liver failure and in severe acute hepatitis, you can treat, and this is the protocol recommended. In acute liver failure, what they have seen is It's not that late stages it will be useful. If you start it early with high potent NAs, you can prevent even progression to ALF, liver transplant or mortality, and this is not seen if you start later in therapy. So this is what we have for the acute. Perinatal transmission, yes, acute you treat the severe acute hepatitis with NAs, with acute liver failure. If you give it early but not later, or they have to go for liver transplant. Looking at the other side, chronicity, reactivation of chronic hepatitis B. It's very difficult to differentiate it from acute hepatitis B because always we feel this child must have been harboring the virus and had an attack. It's very difficult. Jaundice, high bili, high transaminases, but if you have a very high HBV DNA, it is a clue that it is probably an ACLF rather than an acute hepatitis. The treatment recommended is immediately start them on antivirals for all whenever you suspect it, because there they have given a good result and only you give liver transplantation. So reactivation you must treat. What about the asymptomatic HBsAg carrier? Look at that, what is their viral status, look at their liver status, and this is the protocol. We know that this is the phases of hepatitis B. See the arrows, they are going on both sides. Though we have immune tolerant, immune active, inactive viral clearance, depending on the HBV DNA and the transaminases, only the immune active were recommended for treatment so far. EASL has made it more simple and just said, you call it hepatitis when the transaminases are elevated and the liver biopsy is showing trans thing, and you call it infection when the ALT is normal and the liver biopsy is normal. So the terminologies are now more simple and you just have to treat only the red column. So you treat only disease, you don't treat the infection. So in chronic hepatitis, the whole thing is you look whether they are EAG positive or EAG negative, and you will treat only when the EAG is positive, when the DNA is more than that, and even if they are there, you can treat them even without liver biopsy. But suppose you have a fluctuant alkaline ALT or a family history of HCC, then you have to follow them up, do a liver biopsy and treat them. But the other, a normal ALT at present, there is no treatment. For EAG negative, it is more or less the same. You don't treat the normal ALTs, you follow them up. This is one of the things, because we are telling you monotherapy with antivirals, the results is only around 25%. This is a very good study given by Seema's and her group, where they've showed when there's a sequential therapy, it had to higher seroconversions rather than monotherapy, and the baseline of more than 100 indicating ALT is very, very important in the management of the immune active phase. How long to continue NAs is still a dilemma and it is an issue. Many of them say at least for 48 weeks, because in children we can't say give them lifelong. If they are EAG positive, probably seroconversion to anti-HBe can be taken. But the best would be wait for HBsAg clearance. If they are EAG negative, then you just have to continue, because we know that you will get a relapse, a very high relapse rate after discontinuation. What about cirrhosis? Whether they are compensated or decompensated, you treat them not depending on the ALT load. Whatever be the ALT load, you have to treat them and you continue treating them till they go for a transplant. So in the chronic now you have whom and how to treat is now becoming more clear. The only group which we are having this is following up is the immune tolerant or inactive phase. So the apostle guidance says, how do we follow this immune tolerant people is, you monitor them with ALT, biopsy them as I told you when indicated, and treat them when you feel that. So, but as pediatricians we are a little concerned, because adult hepatologists can say follow them up. But we are worried, why should we push a child who has high EAG and then high DNA, who has this risk of hepatocellular carcinoma? Why should they have, why can't we give them some treatment? What is wrong if we give some treatment? So these are the 3 studies where they have done and showed some clearance, and they showed even HBsAg clearance. We had this early study by Vargagni's group, we have a good study by Dr. Yacha Podar, and we had this Chinese study. But then The two studies which recently which I showed you about, Dr. Alam's study showed that when she compared the active hepatitis and the immune tolerant, she was very able to show that in the immunotolerant there was no benefit of treatment with sequential therapy over observation alone. And this she was able to show it very clearly because she compared those who had high ALT and those with normal ALT. And the last thing was the big large trial, US clinical trial, where they gave entecavir, 5 centers, entecavir and peginterferon, and 60 children went through that, and the endpoint was HBeAg seroconversion. Look at that, only 3% attained this endpoint, 67% had adverse infections, and so they gave this conclusion that the combination rarely led to loss of HBeAg, and there's more of adverse effects. So they do not recommend. So do we need to treat all, ladies and gentlemen? This would be my final slide. You treat all the yellow blocks. Yes, perinatal transmission. You treat the mother, you treat the baby. Severe acute hepatitis, acute liver failure, chronic infection, you have to follow them up. So some need treatment as soon as diagnosed, some need treatment after regular monitoring, some may never need treatment, especially the ones who had natural seroconversion. HCC and ESLD may require a transplant. And thank you for your patient listening.